again, the scatter radiation is all about visibility and not so much about sharpness for recorded detail. The way that we limit the effects of scatter is to limit its creation or clean it up after it's created. So the things that we're going to do are adequate KVP. We want to limit the field size in as much as we can. Certainly there are times to leave the field size open, but if we can, we want to limit the field size. Patient thickness, we can't really do a whole lot about. I kind of touched on that on Wednesday. You can use compression, but nobody ever does. Interaction types, all that we just talked about. So KVP, that's just a review of the questions that we intended to answer about KVP. So we went through all that on Wednesday. So mass, just in a tight nutshell, mass really has no effect on scatter. It has an effect on the creation of the mass number of scatters, that's MASS, the bulk number of scattered photon that you create. But generally speaking, whenever we're talking about mass and scatter, we're talking about PE ratio. So as you increase KVP, well, first off, a ratio is one thing compared to another, right? So if your photoelectrics and your matched exactly the number of scattered photons that you create, then you'd have a 1-to-1 ratio, right? As KVP increases, what we get is a lowering of the photoelectrics and a relative increase in the mass that's penetrated through the patient, or relative increase in the competence that are penetrated through the patient. So generally speaking, when we're talking about scatter creation, that's what we're talking about, all right? So can mass have an effect on scatter creation? The answer is yes, but it comes with the understanding that it doesn't affect that at all, right? So whenever you increase your mass, what you get an increase in are interaction types, an identical increase in interaction types all the way across the board. So your PE ratio does not change whenever you increase mass, okay? It remains the same. So in that way, mass doesn't affect scatter. Does it affect the number of scattered photons that strike the image receptor? And the answer is yes. But in context of how it affects the image, it doesn't have any effect on the image. Because with scatter, what we're talking about is the degree of fog versus good signal. It doesn't change that. It just, we've got too much good signal, and now we've got too much scatter radiation too. So it increases all of that equally. So the PE ratio remains the same, and therefore we say mass does not affect PE ratio. So what you would look for in a question that asks about mass and its relationship to scatter radiation is if it's just a standard, what effect does mass have on scatter radiation? Your answer is none. It may ask something along the lines of how does mass affect your image, the scatter radiation on your image, and it does not, okay, because that's PE ratio. How does mass affect your visibility? It does not, unless you get into a mass value that's so high that, or so low that you just can't get a good image. In that way it does. But if we're just talking about the how much more scatter are you going to create that might interfere with the visibility on the image? It doesn't. So you might have a question that says, as mass increases, the overall number of scattered photons goes up. Would that be true or false? Overall number, well, what is mass? If you increase your mass, what happens? You get an overall increase in all interactions at the same rate, right? So in that context, yes, mass increases scatter, but it increases everything, right? So since it increases everything, it has no effect on visibility or contrast. It only affects the overall number of photons that are scattered, right? But the PE ratio remains the same. So most of the time, when you read a technique question that's asking about scatter creation, first off, most of the time it's going to be KVP in it, but in the rare cases asking about mass, the effects of mass on scatter creation creation, or except for in that one case, there's no effect. Okay, so just look for that. The bulk numbers, the overall number of photons the scatter photons that you get. Yeah, that's going to go up with an increase in mass. But in the tube, really, it's just all about electrons, gross number of electrons, more heat. So with an increase in mass, you get more electrons going across the tube, create more heat in the beam. You get more electrons or more photons of all energy levels. In a patient, more interactions inside the patient on the image. Scatter radiation and the effects on visibility or recorded detail, it just doesn't. Sharpness or recorded detail, possibly in two different ways. One with blooming, really both having to do with blooming, or both having to do with focal spot size, actual focal spot size. One because of blooming, and one because you just can't select the small focal spot at certain MA values. So KVP changes scatter ratio, the Compton to PE ratio, the percentage of scatter. It increases exposure. The effects on sharpness of recorded detail with KVP, you don't have any. It's all about visibility. Effects on patient dose would be depending on whether or not you were using the 15% rule. You increase your KVP and reduce your mass, your overall dose decreases. But if you're just increasing KVP, then your dose to the patient increases. So with mass, scatter, none. Exposure, as mass increases, exposure increases. Sharpness or recorded detail, possibly with mass. No change in visibility or recorded detail, and the effects on dose are direct. So with KVP, remember it's direct, but it's exponential. With mass, it's just direct. What I try to tell y'all are the things that I've seen in registry review books, and give you a heads up towards those. So some things like in patient thickness, and the reason I went into this is patient thickness. Some things I've seen in the registry review books are kind of represented sometimes in the PowerPoints. Like, for example, do changes in patient thickness affect X-ray production? No, the X-ray tube can't look at the patient and say, okay, I need to beef up something because I got a bigger patient than the last one that I had, right? So the answer is no. Another one that I see quite a bit is there an increase in production as you increase SID? And again, no, the tube can't tell that you increased your distance from 40 to 72 inches. It can't. Maybe one day they'll write a program that compensates for all that for you, but it can't. So what it does detect, though, in photocells and whenever we're using automatic exposure, is the amount of radiation that's coming through the patient, right? And I doubt that they're going to do that increase in distance thing because of that. If you're phototiming, it's going to take care of all that for you. So just the changes in patient thickness or SID affect X-ray production? The answer is no. But what happens when you're phototiming? Because I want you, that first question is what I see in the registry review books. And the answer to that question is universally no. But I want you to understand the context there. What happens when you're phototiming though? You increase your distance. What happens to your X-ray beam? Spreads out because of divergence, right? So you collimate in, right? What that means is that radiation detector receives less radiation. So this is obviously an increase in SID. So it receives less radiation. So if you're phototiming, the phototimer is going to stay on longer to receive the right amount of radiation, right? So in that case, does the X-ray beam, do we get an increase in production at the X-ray beam? The answer is yes, okay? So, I want you to understand all of that, not just as you increase the distances or increase in production. No, I want you to understand the full context of that. So when you set a technique, no change, you have to make that change, right? But if you're phototiming, the machine takes care of it for you. So same thing with patient thickness. As the patient gets thicker, then if you're phototiming, the phototimers are just going to stay on longer to receive the right amount of radiation before sending the signal over to the timer circuit. Discontinue. Okay? But when you set a technique, what's going to happen is your index number is going to show up that you underexpose the patient. So we talked about this on Wednesday. Patient thickness affect penetration, and the answer is yeah. As we increase thickness, patient thickness, it's going to create a lot of scatter. That scatter radiation. Scatter is basically partial absorption. So it bounces around inside of the patient and loses energy. The X-ray photon loses energy with each one of those interactions. Eventually, it's going to absorb inside of the patient, and penetration goes down. Okay, so we have a tendency to think of penetration as KVP, right? And this is where you're going to have a tendency to want to tie KVP into patient thickness, so you get less penetrated photons. Do you want to increase your KVP? And I know I went on that whole KVP thing at the end of the lecture on Wednesday, but right now our technique compensation is always mass, right? Mass. So until that changes, and I don't see it changing before you graduate. If it does, we got to turn on a dime and be ready to go with it. So, so do changes in thickness affect occupational dose? Well, where does your dose come from? Scatter radiation, Compton wide angle scatter radiation. So potentially, so you know, you're doing let's say an LP or myelogram on an asthenic patient versus a hypersthenic patient. A hypersthenic patient is going to create more scatter radiation. All right, so we've walked through this. How do you limit your dose in a fluoro case? Okay, you're getting ahead of me. That's step 2. Step 1 is, it's right there in the question, step back, right? So you double your distance away from the source being the patient, then your dose drops by a factor of 4, right? And then, you know, you nonchalantly slip over behind the PA or the radiologist, your dose goes down. More important in hypersthenic patients than in asthenic patients. Important in both, but more important in hypersthenic patients because more Compton could potentially increase your occupational dose. So, scatter production. Okay, so to boil down, I gotta get done. To boil down, really the next 2 sections in this particular chapter, with patient thickness and area irradiated, more tissue, more scattering. Okay, it's just it. More tissue, more scattering. Thicker the tissue, more scatter radiation. The bigger the area, more scatter radiation. Okay, so regardless of what it is, if it increases, you can create more scatter radiation. So naturally, the less you irradiate, less scatter. Right. So now with the thicker patients, are those photons more likely to penetrate through the patient? The answer is depends, really. Where's it penetrating? Is it penetrating to the image receptor? And the chances are probably not more likely to penetrate. Are you going to create more scatter that bounces around the room? Well, maybe, right? So if you have a hypersthenic patient versus an asthenic patient, you're going to have to increase something to get the same exposure to the image receptor, and that something, for now, is always, say it with me, mass, right? If you don't, then your image receptor exposure is too low. Okay, so I think we've hit all of that. So just running through it real quick. How does it affect contrast? Not a whole lot. Grayscale, still not a whole lot. Exposure decreases as thickness goes up. Sharpness, well, you do actually have some changes in sharpness because you may have some increases in OID, right? Absorption, blur, and all of that comes into play. The things that we talked about in the last section. And visibility, anytime you have scatter. Right, technical factors, mass, field size questions, where we're going next. Any questions?